Hey everybody, welcome back. This is John Malanca, Dr. Jordan Tishler, and Dr. Jahan Marcu with the Association of Cannabinoid Specialists for our casual conversations. I hope you've been enjoying this series certainly as much as we are. Today's topic of discussion is pain management as well as opioid sparing, and these are two topics that come up quite a bit. And for our medical professionals out there, maybe you're seeing a lot of patients that are coming to you asking about these questions, and that's why we do these little segments here. And so welcome Jahan and welcome Jordan. Love to get your insight on what you see with your patients and where do you see this going as well?
I'll take a crack at this question. As you know, the combination of cannabis and opioids is an old story, goes back a long ways, but the reason we're focused on it today is probably largely because I believe, due to observations made by my colleagues Amanda Reiman and Philippe Lucas. Amanda Reiman in 2009 published her study on cannabis as a substitute for alcohol and other drugs. And this gave us a first real-world peek into a dispensary and why patients are using cannabis, and really the kind of the first person to ask, for patients to say how much alcohol are they drinking, how many prescription drugs, how much of other drugs are they taking, and it seemed to be across the board, decrease. 40% reported substituting it for alcohol, over 66% reported substituting it for some sort of other prescription drug. Now you fast forward a couple years, our neighbors in the North, Canada, with Dr. Philippe Lucas, he looked at cannabis as an adjunct to or substitute for opiates in the treatment of chronic pain. So kind of, in my opinion, building on what Amanda Reiman had observed. And so he published this work in the Journal of Psychoactive Drugs, starting to show like, wow, there's this chronic pain population that seems to be tailoring their doses of opioids or opiates and cannabis products. However, what's interesting is that the biological exploration, the basic research, the scientific exploration into this happened almost a decade or even 20 years before. So starting around the late 80s, researchers started to notice things like THC stimulates beta endorphin production. So that's an interesting thing, right? Like we're looking at endorphins, and endogenous morphine is what they're short for. These are the body's natural painkillers, and THC stimulates the release of these. And so that already indicates some crosstalk. THC can interact with these endogenous opioid ligands. This has been shown in several different basic research studies. In 1999, there was a study that proposed that THC may allow for some clinical opiate sparing, that is, using less opioids to achieve pain relief in particular instances, not across the board, but in certain pain conditions. And there seemed to be some evidence under the right conditions, THC could prevent the development of tolerance to and withdrawal from opiates. And this is looked at in rodents, and it showed very promising results. And what seems to be interesting is the crosstalk between opioids and cannabinoid signaling, as we both have endogenous systems. Donald Abrams showed in a study with morphine that you could administer less morphine if the patient had THC. And so they're starting to find these balances. Researchers have even started to explore, differences between codeine and morphine in terms of, well, how much of a cannabinoid signal or stimulation do you need to start to reduce reliance on those opioids? And, research has shown that there's probably, according to one review, about 28 studies that provide data relating to the potential opioid sparing effect of cannabinoids in terms of opioid pain relief. And this should not be understated. We have a rapid increase in opioid use and opioid associated mortality in this country that continues and around the world. And again, the race is on to find medications to lower opioid doses and potentially reduce opioid related mortality. Earlier this year, colleagues and I published a retrospective study looking at patients who had become medical cannabis patients in Delaware. But we looked at very specific pain populations to track their opioid use. So I think one thing that's important is when we think about cannabis, cannabinoids, opioids, and pain, is to think about what pain population are we treating? What type of chronic pain? Is it, neck pain? Is it back pain? Is it pain related to neuropathy? I think what this clearly shows is that there is a signal here that needs to be explored, because the results, I think, are so promising that that they really warrant trying to build out studies that can be replicated in large, well-designed studies. And it would be great if we could, study this in, with real-world products. It would be amazing to start to zero in on, okay, we've seen cannabis patients. There's reports they use products. They use less opioids, less prescription drugs. That seems to be a trend in some cases, but it's not across the board. Just having a medical cannabis law passed in your state doesn't mean that like opioid use will go down.
I think that, when I think about the evidence around cannabis use for pain management, first of all, I tend to think about pain management as somewhat separate from the issue of opioid use, right? And my first question is always, all right, does the patient feel better, right? Are we making a dent here on the problem? And then sort of as a second question, does this mean that they can use less opioid, which obviously has the benefit of being less risky? But, patients come to me and they say, I want to get off the OxyContin. And I always say to them, you know what, that's fine. But, there's kind of a negative thing. I want to stop using something that's sort of otherwise helping. How about let's focus on making you feel better? And if we can do that with cannabis, naturally, you just end up using less opioid, and it doesn't become kind of this thing like, I have to stop, I have to get away from this, which is a lot of pressure and a lot of negativity. There are a number of studies, as Jahan has mentioned, that have shown in this sort of observational manner that cannabis can be helpful not only for pain, but to reduce opioids. And the series that I've seen show somewhere between a 40 and 80% reduction in total opioid doses. But there have also been actually older studies that were better studies, that they were actually randomized controlled trials. And so I just pulled up a slide from that contains some of the information. So in 1974, back when the dinosaurs roamed the earth, there was a randomized controlled trial done in non-cancer related pain by Shirley Hill, William Schwinn et al., published in the Journal of Pharmacology and Experimental Therapeutics, that showed significant benefit for using cannabinoids over no treatment at all. Also in 1974, a randomized controlled trial of spasticity and spinal cord injuries done by Dunn and Davis, published in Paraplegia. In 1975, a randomized controlled trial showing analgesic benefit at doses as low as 10 to 20 milligrams on cancer pain, done by Noyes, Brunk, and Barham et al. So, we don't have to completely rely on these ecological studies, these driven by these apps. We've actually got real randomized controlled trials. And I think that's one of the things that really led to the review in 2017 by the National Academy of Sciences that said that there were many areas of cannabis and cannabinoid medicine that remained to be fully elucidated, but that when it came to pain management, the word they used was incontrovertible. And I think that was very reassuring to me. Obviously, I'd been doing this for a while already by the time they came to that conclusion. And so, I think that when it comes to pain, there's pretty good evidence at this point. And certainly in my practice, I'm seeing a lot of benefit to patients. Whether we're able to reduce the opioid use, I think is, as Jahan had said, so certainly much more up in the air and needs to be followed more closely.
Yeah. Well, let me back up, Jahan. I loved how you said potential, because a lot of people, I want our followers and the physicians and medical professionals that are just learning about the Association of Cannabinoid Specialists, that cannabis is not a one size fits all. It doesn't work for everybody. It's not for everyone. And I loved how you said that potential, because a lot of companies will say, I never use the word cure and never want to give anybody false hope. With Dr. Abrams, he shared a study, I think back in 2011, and it might have been his study or something that happened at UC Med, but he spoke about a hot plate with a rat putting his tail on the hot plate. And of course, the rat's like, wait a minute. And then they injected him with THC, and the rat, stayed on a little longer. Not animal cruelty, but just showing that it does work. With cannabis being legal in 38 states and growing, this topic comes up. And so can you share with our audience how cannabis works with the pain receptors? Why?
This is probably one of the most explored areas in basic research. And so the mechanism of stimulating members, proteins, targets of the endocannabinoid system for an anti-inflammatory, for a pain effect has been tested in every type of animal model you can imagine. Repetitive stress injury, chemotherapy agent exposure, bonks on the head, you name it, IRB has approved it for study with cannabinoids. And many of these studies continue because the results are often surprising. But, what is interesting is this mechanism inside of mammals, like rats and humans and things like that, mice, has been, preserved for a really long time because of its ability to help manage pain. And it is distinct from how opioids work. Opioids, I didn't study my thesis studying opioid receptor interactions, so I'm just going to say succinctly that, the opioid efficacy is very much related to activity at what are called mu opioid receptors. There's kappa opioid receptors and so on, but it's just this interaction at mu opioid receptors that sort of creates the buzz around pain, if you will. When it comes to cannabinoids, we have these distinct mechanisms, because when we talk about cannabis, we're not talking about one compound like morphine. We're talking about things that go in different directions, like THC and CBD. So the combination of THC to CBD has been super well studied for pain, especially spasticity pain in MS patients, multiple sclerosis patients, in the form of a nabiximols, as it's called, or Sativex, a CO2 extracted hash oil that has even parts of THC, CBD dissolved in ethanol and sprayed under the tongue. It's a licensed pharmaceutical drug in 30 something countries. It is still under review in the US for the last 20 years or so. But it is remarkable in terms of the chronic pain effects it is having. So when we talk about THC and CBD, what we're talking about is a combination of things. So THC stimulates the CB1 and CB2 receptors, cannabinoid type 1 and type 2 receptors. These are receptors that are located throughout the body. And CB1 is mostly associated with being in neuronal tissue in the brain and helping to regulate pain signals that way, while the type 2 receptor is thought to be more involved with the immune response, immune cells, and inflammation, helping to sort of work on inflammatory pain and those types of issues. CBD has a very interesting way of going about handling pain. It involves potentially the TRP receptors, the transient receptor potential vanilloid type 1 receptors. It's a beautiful name for a beautiful receptor. But the TRPV1s, the TRP family, very much involved with pain and swelling and temperature, like chemical burns. These are some really interesting ion channels. And if you eat a chili pepper and your mouth feels like it's burning, or like you're getting little bites in your mouth, it's like picante, right? It's little bites. Those are the TRP receptors, like getting triggered. And so you can imagine that if you had something to target those, you could have some pain relief. CBD also can work at serotonin receptors. I believe it's the 1A receptor. I'd have to double check, but this may be part of how CBD can have a pain relieving effect, and also potentially through adenosine receptors. So THC and CBD have these distinct mechanisms that kind of converge on the same physiological effect, which is reduction in pain sensing and reductions in inflammation. And it might be a combination of the two that makes it such a valuable product for people with certain types of pain. Opioids can depress breathing, but cannabinoid receptors are really scarce in those cardiorespiratory centers, in contrast to opioid receptors. And so if you can use less opioids and get pain relief, I think could be a much safer option. And what's also fascinating is, as while we're talking about combining drugs, there is no evidence right now that exists to point to clinically relevant adverse drug interactions between cannabinoids and opioids. I know it's really easy to say, like, oh, well, the absence of evidence, but right now that it really has not sort of floated to the surface in investigations, which I also makes this a tremendous potential. And why we say it has tremendous potential is because the mechanisms are very well published and discussed. You can design an experiment in a model of cells or animals based on this mechanism. And usually your hypothesis will be correct based on how we understand these things to work in physiological systems. In human beings, it starts to get more complicated as pain can be more complex. And so when we think about humans, we can't just think, oh, it's one size fits all. If you go on, clinicaltrials.gov, you'll see a lot of pain studies in the works. We see states banning cannabinoids, putting limits on potency. How will this affect people who need high potency products, need specific products?
All right, I have to jump in. I don't know anybody who benefits from a high potency product. Okay. After tens of thousands of clinical encounters, this is one of those things that I think is an industry-led misunderstanding.
What to define high potency then? Because I'm thinking above 10% THC. Because that's been a cap.
Okay. All right, fine. So I'll give you up to 20% if we're talking about botanical flower. I don't think that there's a lot of value in over 20%. But I was actually thinking in terms of total milligrams, whether we're talking about by inhalation or by oral ingestion.
I think this is a good point for the listener or the observer of our conversation, because when we talk about these products, mostly what I'm talking about is not seeing people consume pure, crystalline THC that's been extracted in butane. What we're talking about is usually more traditional preparations of these products that have been around for flour and things like that. And my concern, Jordan, is around the stuff like New Jersey tried, which was, we're going to put a 10% cap on THC or all cannabinoids. And it's like, well, I mean, where's the evidence to support that? It's much different than saying, we're going to put the cap at 80% THC by weight. But I think, you bring up a good point there about potency and how it's discussed in terms of cannabinoids, because a lot of clinical research has looked at relatively lower potency cannabis, like the stuff from Mississippi. Say what you want about it, it's been consistent for decades and not one recall, and it's shown to have medical efficacy in terms of reducing pain and having other benefits at between 3 and 8% THC. But again, these are small scale studies. You can pick them apart if you want. But thanks for clarifying the potency thing. I think that's always good to kind of revisit. What are we talking about when it comes to people using these products?
Absolutely. And I think that, in some ways, because of the botanical nature, we've gotten very fixated on this percentage by dry weight. But ultimately, if we're thinking about this as a medicine, we need to be thinking about numbers of milligrams ingested, right? And you can get there in a number of ways mathematically to figure it out from that percentage of potency in flower. But ultimately, we want to know how much is down the hatch or in through the lungs. So, just to kind of clarify my perspective on this, what I would say is that I have a smallish handful of patients who do find it as little as 5 milligrams, a tiny fraction down at maybe 2.5 milligrams. I would say on average, my patients who have pain are getting their best benefit at around 10 milligrams. Now, that's 10 milligrams a couple times a day, but still the point is that when you say that to somebody who's sort of an experienced cannabis user, they start to laugh. And they say, I have to take 100 milligrams or whatever. And to me, that's not a statement of the efficacy of 100 milligrams. That's a statement of where you ended up in terms of misuse of your cannabis and driving your tolerance up by downregulating your endocannabinoid system and your receptors. And I have plenty of people, unfortunately, come to me saying, you know, I'm taking 100 milligrams and I'm not getting what I need from it anymore. What do I do? And so that puts me in this interesting position of trying to treat their pain while at the same time gently move their dose back into a more healthful range. And it can be done, but it's a lot harder than starting with somebody who's never touched cannabis and sort of working our way up to that sort of 10 milligram average dose. And at those higher doses, what do we see? Not better pain control, but more dependence formation and ultimately a greater risk for cannabis use disorder, which I, like most people in the cannabis world, used to think was kind of a conspiracy theory. But I got to tell you, after seeing many, many patients, it's thankfully rare, but cannabis use disorder is definitely a real thing. And it's something that we can avoid if we're giving our patients proper guidance on these things and the kind of routine follow-up that is normal in other fields of medicine, but somehow is not in the cannabis medicine field.
Absolutely. And I like what you said there. And I would add, just to go back to the kind of evidence from clinical studies, a lot of studies have looked at oral cannabis or look at pure dronabinol, 5 milligrams, 10 milligrams combined with morphine, and they're not seeing either a statistically significant effect on pain or decrease in opioid use. However, in the two studies that used vaporized cannabis, which was, you know, Abrams' study, and another one that looked at smoked cannabis of an unknown content, just the participants, you know, due to the federal regulations, they just sort of, yep. That's where we're seeing these significant reductions. Now, you know, inhalation studies with cannabis, again, you can pick them apart about how well controlled they are. It's a little, you know, obvious who got the placebo when the drug sort of wafts in the air. But you know, I find it interesting that it's difficult to replicate these findings with oral administration of pure THC. And yet there hasn't been a comparison yet, or a good one that I'm aware of, that compares oral THC, inhaled cannabis, and then, you know, each group, say, looking at their opiate use in that way. But one thing that might provide clarity on this, Jordan, and maybe you want, you know, or John, you want to comment, is, you know, looking at these sort of, you know, what do you call it, whole plant extracts with 10 milligrams of THC and all these other components, maybe trying that orally with a little bit of CBD, a little bit of CBC in there, and these other alphabet soup of cannabinoids. Maybe we might see the effect there, because I kind of feel like some of these studies where it's inhaled cannabis and looking at opioid use and additive pain effects, searching for that, versus pure THC and an opioid, it's a little bit like apples to oranges. You're comparing like this shotgun of compounds going into someone's body very efficiently to, you know, this sort of sniper shot, silver bullet, one compound that, you know, can take an hour or two to kick in. Yeah. So I find it a little frustrating when you look at the data.
Yeah. And I'm glad you followed up with that, because that's one question that comes in all the time is, what do I give my patients? Is it smoking? Is it vaporization? Is it edible? Is it a topical? You know, and hopefully one day it'll get to be the point, you have this pain, take this, you have that pain, take that. Let me back up on the drug interactions. And for our listeners,
I gotta jump in with a couple of thoughts here.
First of
all, let me tell you from clinical experience that dronabinol is not cannabis. Even putting oral dronabinol against, you know, commercially available edibles, there's no question that dronabinol is a poor choice. It is what's available because it's what made it through the FDA process. But I've done this unofficially, and there's no comparing these things.
And doesn't sometimes it take like another prescription 10 days to get in the system, and sometimes it works and sometimes it doesn't? I've worked with patients that they've tried it, nothing, and then they try an actual whole plant medicine cannabis, and they go, I'll be darned, you know. I wasted 10 days of this other pill that my doctor prescribed, and I went and ended up getting some just cannabis, and I'm saying pain free, but I have more relief than I had taken
It's
dronabinol.
very much less effective for pain management, and it's also very unpleasant to tolerate compared to sort of the equivalent dose of a whole plant product.
It was ingestions, ingesting via smoking, vaporizations, edible, topical.
Yeah,
Maybe
well, I
that's
mean, we
So to
don't
your
want
point-
people to smoke, right? I mean,
Yeah.
that's ideally avoid that, but there are options for people who want to use a good quality vaporizer.
Right. And when at least I'm talking about vaporizers, I mean a flower type vaporizer that has a microprocessor temperature control in it, and not one of these ubiquitous little vape things that actually combust stuff.
I'm pretty sure those pens are for novelty purposes only.
I hope so. I hope so. I hope they go away like that. But the other thing is, to your point about being able to say, well, you take this for this and this for that. We've got data on this, and we've got a handout. I mean, it's sort of like, when, for the doctor in the audience, when you were back in the day, when you were a resident and you had one of those spiral bound books that you carried around in your dorky white coat, or for the younger docs, Hippocrates on your phone. We've got that kind of a resource at the Association of Cannabinoid Specialists that's available to every member. And we call them our handbooks. And there's one that's aimed at docs, and there's one that's aimed at nurses. And so those things are available. They're not the end of the discussion by any means, but they are a good place to start.
Absolutely. And Jordan, I think it's always good to look at these materials and learn more about cannabis and why pure THC or a lot of THC and very little of something else will work differently than THC in combination with stuff. And there's this interesting study from the name is Katsuyama. It's from 2013. They looked at beta caryophyllene, and that's a terpene from cannabis. It's one of the most abundant ones, and that's just the way I like to say it. There's other pronunciations, but that's my preferred pronunciation.
BCT. Hey, everyone mispronounces your first name, and it drives me nuts. And you let everyone do it. That's a thing. You're like,
it's just I don't even hear it anymore. It's been so long. But this terpene, beta caryophyllene, like it's at doses where it was like kind of ineffective on its own, didn't really seem to do anything. It had an effect when combined with morphine in terms of extending sort of morphine-induced pain. And this is an interesting aspect. And again, it's in animal studies, but it's very interesting that a terpene, a smelly compound from cannabis, has pharmacological activity, and it is confirmed that it has pharmacological activity at the type 2 receptor. So some sort of anti-inflammatory response mechanism is being triggered, and in combination with morphine seems to have a benefit in terms of extending the pain relieving effect. So again, just to say, it's not all about THC. I think it's an important factor, just like CBD is an important factor, but researchers are teasing apart these individual compounds and finding that they do have a mechanism that might be an important factor that adds to overall beneficial effect.
Yeah, and we've got products out there that are THC, CBD 1-to-1, but if they're made from isolate, they're ineffective compared to ones that are made from a whole plant extract. So there's clearly other stuff besides those two major players that is effective. And I think the beta caryophyllene is probably high on that list.
I think a lot of patients prefer smoking and vaporization due to the instant onset in most cases. Can you talk about why instant onset works with that via a tincture or an edible?
Sure. So inhalation, it goes right to the lungs. The lungs, what they do, they help to absorb stuff from the air, right? So they have this thin tissue. It's great for diffusion of oxygen and whatever else is in there as well. So it can be a great simple way to get it directly into the bloodstream. And it's been reported that many patients are able to titrate their dose because they can feel the effects of it. However, smoking, just to harp on it a little bit, is extremely wasteful. You're burning it. So you're probably losing half of the material when you're burning it. Then you're inhaling it. There's loss of side stream smoke. And then how much is being absorbed when it's inhaled, and does really holding your breath for 10 seconds make a difference? Probably not.
We know that from 1990 study.
Yeah. And so, so I think when we think about vaporization too, it's not as wasteful, but you still are exhaling a lot, losing some through the side stream. So you might think you're loading a lot into the vaporizer, but what's reaching the target site may not be as much as you think. But it's a very easy way. Now, contrast that to something that's, say, a tiny little spritz or a drop of something, dissolved in ethanol, for example. And I'm only advocating for mixing cannabinoids and alcohol in the form of a tincture for medical purposes. Not, I'm not saying, oh, well, hey, I heard this was safe, so I'm going to have a beer with my joint. Like, no. We're talking about using the alcohol as a delivery vehicle, so it's absorbed under the tongue. And this is actually a little tricky for patients at first, because if you swallow it, then it's going into your gut and it's getting sort of like a typical pill that you're swallowing. But if you let it absorb under the tongue, it can go right to the brain and be a very targeted, quick effect, similar onset to an inhalation of cannabinoids, according to some reports in the literature. So I think when we think about inhalation or sublingual applications, we're talking about rapid onset for the purposes of decreasing the abuse potential. In my opinion, is the goal, right? I think issues arise when people take something, they don't feel anything, so they take more, they don't feel anything, and then they take more, and then it's just like kablamo, what happened? And then they're calling the poison control center or going to the ER, just as a extreme hypothetical situation. And so why do people like the rapid onset? So that they can take as little as they need for as big of an effect. And again, I'm not a medical doctor, so I'm gonna pass it to Jordan to correct anything or fill in any gaps there with patient care.
I think that, actually it's interesting. I mean, what you say about the stacking and surprise effect of edibles is definitely a real issue for people who are new to this substance. I would argue that it is really incumbent upon their physicians to have set the stage so that that kind of thing doesn't happen. And believe me, I spend a lot of time setting that stage, and I don't think I've ever had anyone in the deep end of the pool because of that. In terms of the abuse potential, there's, people worry about the inhalation because the rapid onset does tend to trigger a fair amount of dopamine release, which, then reinforces the behavior. Again, in my clinic, I don't see that be a problem because number one, we're using small doses, fairly few inhalations, and also the continual monitoring and discussion with the patient kind of tends to keep people on the ranch as opposed to sort of floating off into the breeze. The issue in my mind about tinctures is that most tinctures, most of the data for oral mucosal absorption come from pharmaceuticals like Sativex and Epidiolex, which you mentioned earlier, and those have a fair amount of research and technology involved. When we start to think about the garden variety tinctures that one gets down the corner, we're basically looking at extract that's been then transferred into some oil base, and those things don't seem to absorb very much at all, if at all. And that we know that there's a fairly strong sort of Pavlovian overlay, which is to say that if people put something under their tongue, they often feel what they expect to feel, but measured blood levels don't reveal any actual absorption. But the biggest thing I have that steers me away from tinctures, except in rare conditions like I have a patient with MS or ALS and they have a feeding tube, they can't take things by mouth, then tinctures work all right down the tube. But in people who can
even with a alcohol base over an oil base, I just the patients that we work with, they don't like the burning sensation. A lot of them are sensitive, and so that's
that John, that's such a good point, and that is one of the main side effects of Sativex that's reported is people spray ethanol and they actually get little ethanolic sores because ethanol can dry out the mouth a little bit, so they can, if you're spraying it 12 to 15 times a day, as a lot of people are, to again for like treatment-resistant multiple sclerosis and spasticity issues, yeah, that is a potential side effect as well. Is it effective for getting it in the bloodstream? Sure.
Yeah.
But yeah, it has some effects people may not like.
Those scores were the number one reason that people dropped out of the studies, right? So the question is, okay, yes, this can work, but sort of in the real world, why are we going there? And the other thing I have a problem with tinctures is they're liquids, which makes them very easy to screw up, pardon the expression, right? I mean, if you're like, what am I dropping? Is that 10 drops or 15 drops? So first of all, if I'm having somebody use a tincture, I always tell them, get a spoon and count the drops onto the spoon. Don't count it in your mouth. But generally, I will go to a gummy where I know that they're getting 5 milligrams. And if they need 10 milligrams, they take 2 gummies. But then it becomes a question, did you take your gummies? Not how much did you get? And so generally speaking, I prefer those with those few exceptions that I mentioned.
Sorry, I was going to say, Jordan, I think for a follow-up discussion on this, it'd be interesting to discuss the difficult to treat populations, because you can't, it sounds like what you're saying is for your practice is there isn't a one size fits all administration form that it's like a go-to. It almost depends on a lot of different factors, on their dexterity, for example. I think you brought up a great point about using those droppers and the way those products are administered. Like, yeah, if you don't have a great dexterity to use that, you could have a unfortunate experience by overdosing yourself, I guess. I have to be careful how I say that.
Oh, yeah, exactly.
I have a note here which goes to your point, Jahan, which is, at least the way I tend to think about things isn't so much about the way it gets discussed in the community is sort of, what is your preference for the modality of delivery? And, we don't really ask that about your blood pressure medications, your asthma medications. And I tend to think, perhaps because I'm a physician, in different terms, right? That is to say, inhalation, as you mentioned, is rapid onset. It's also fairly short in its duration, more like 3 to 4 hours. And so that makes it a good approach to sort of acute or episodic problems. And the classic example I give is a migraine headache, right? We want, when that headache just starts to happen, we want to get in there and turn it off. And then if that headache goes away, we want the medicine to go away too. So that's a great example. Whereas, on the other hand, the stuff you take by mouth, like a gummy, right, that takes a while to kick in, which is kind of a bummer. But because it's chemically altered by first pass metabolism in the liver, we're actually treating with a different medicine, which then leads to a much more extended duration of action, which makes it a much better treatment for chronic pain. The person who has that sore neck or the arthritis in their back, where they need that, they have arthritis in their knee and they're not ready for a knee replacement, that sort of thing. Those people do better getting a nice sort of even level of pain management, and the edibles work better for that. So that's kind of the way I think about that.
I'm going to take the other side here, because I am a fan of cannabis and the benefits on, I always talk about in my slide presentation, having a roll of duct tape, and people look at me and go, hey, you have the wrong slide. And I say, I don't want to say it's like duct tape with 1,000,001 uses, but when you really get down to it, of all the studies that are out there on cannabis and the different cannabinoids and the terpenes that you're mentioning, Jahan, it'll blow your mind. Back to the side, I'm going to, because we probably have some listeners here. They're like, nope, don't believe it. My wife, Corinne, pancreatic cancer. And I remember she had zero pain control with cannabis. And she just looked at me with these eyes like, how is this not working on me? This is what we've been sharing. These are all the studies you're showing, and it's not working on me. And to see that, and she was not a smoker. I had her trying smoking. She was not she tried vaporization, smoking, edibles, tinctures, and she just looked at me like, why isn't this working for me? And it's awful when you see your wife or loved one or any of your patients go through pain. And it's bringing up emotions right now for me, because I remember those days. And so what can you share for our listeners that are probably the same way? Like, come on, I don't I don't know enough to keep
Medicines
on.
aren't magic,
Yeah,
and so some people are going to do really well with them. Some people are going to do okay with them. And I've certainly had my fair share of patients who have not gotten what they needed out of it. On the other hand, and let me take a moment to say I'm sorry, that it didn't work for Corinne. But sort of, in medicine in general, if we find a medicine that works sort of 40% of the time, we consider that a home run. And I would say, based on my experience in the clinic, I'm getting sort of 80 to 85% success rate. So I'm not sure what it comes after a home run. Maybe it's a grand slam or something. Enjoy the metaphor. But the point being is, it's not for everyone. Some people can't tolerate the intoxication, which I view as a side effect. And some people just don't get the analgesia out of it that they want.
Yeah, I think that's such a great point, Jordan. And some people get a transient sort of effect, like it might, oh, the muscles relax, I feel a little better in that area. And in some types of pain, it seems to almost draw more attention to it. And then I think that's an important consideration when we're talking about patients trying products. Like, don't go to the high potency stuff. You really want to use as little as possible and stay in that zone to see what type of an effect it will have. I mean, there's so many factors when it comes to humans. We haven't even talked about, how do people metabolize cannabinoids? And that varies in the population. And just like your point about the 30%, 40%, hey, yeah, if you can have 40% success with a drug, I mean, hallelujah, that's a blockbuster right there. I mean, look at Epidiolex doesn't even put up those numbers. At least from the last results I read was, about 30% have no change in their, seizure scores, epilepsy scores. 30%, have a significant reduction. 30% stay the same or get worse. And that's a FDA approved cannabinoid product that's, very popular. And again, it is again, like I said, a very popular drug for pediatric epilepsy. And, it's looking 30 to 40% success rate with that. And it is for those that it works for, it's like miraculous, right? It's almost magic. And for those that it doesn't work, it's just one more thing you try, one more arrow you pull out of the quiver to try and like shoot away disease, to paraphrase a old saying.
Yeah, the next conversation we're probably going to cover is the drug-to-drug interaction. Then, Jahan, I know you mentioned cannabis being legal in 38 states and growing. I think it's a topic that we definitely should discuss. We will probably have a pharmacist on here who specializes not only in pharmacy, but also cannabis. And love to hear your insights. And if you have any questions, please reach out to the Association of Cannabinoid Specialists, And Jordan, do you have a phone number you want to add to it as well as the website?
Well, let's point everyone to the new URL. The new URL is cannaspecialists.org. So we tried to simplify a little bit. So it's
cannaspecialists.org, O-R-G. And again, thank you, Dr. Tishler, Dr. Marcu. This is Jahan Marcu with the Association of Cannabinoid Specialists. We will see you next time for Casual Conversations. Have a great day, everyone. Bye-bye.